Welcome to another episode of Reboot with Dr. Arasi Maran, a podcast where we explore health, innovations, and the medical professionals who make a difference. I'm your host, Dr. Arasi Maran. I'm a board certified interventional cardiologist, and my passion is to increase and improve the healthcare awareness of everyone, not just my patients. So today, I have the privilege of being joined by Dr. Lisa Trito, a pediatrician and a fellowship trained specialist in pediatric obesity medicine. Dr. Trito practices at Evora for Kids, a St. Louis based clinic offering both in person and telehealth care for children and teens with weight related health concerns. So, Dr. Trito, thank you so much for joining me today. I truly appreciate your time. Before we dive in, can you share a little bit about your journey into medicine, what made you become a physician, and specifically this very relevant topic in pediatrics?
Sure. Yeah, thanks. I'm so glad to be here. My journey into medicine, I started off wanting to be a nurse and started off in college, and one of my college professors told me, "Hey, you're really good at this. You should become a doctor." And I'd never even thought about that before. I don't come from a family of medical providers. In fact, I was the first person in my family to go to college. Always knew I wanted to work with kids. And I was, going to subspecialize after residency, and life got in the way, and I started having babies, and so I I chose to stay in general pediatrics, and so I did that for many years, over 20 years, and all along the way, I was always frustrated with not being able to help people with weight, and had weight issues myself, had weight issues in loved ones, and thought I was giving all the right advice and doing all the right things, and it just wasn't adding up. And I knew there was more to it. And after 20 years in general pediatrics, I was ready for some kind of adjustment or shift. And so I learned about obesity medicine as a specialty, and found out about this fellowship at the University of Minnesota. And so I went there and spent a year with some of the best people in the field, and learned so much from them. And now I am just focusing specifically in pediatric obesity. I'm not doing the general pediatrics part anymore, although general pediatrics is really part.
If I'm correct, there are not many places in the country which offers this subspecialty of pediatric obesity medicine.
Pretty unusual. I mean, I'm the fourth person to go through this program, and there is another one in Colorado that are specific for pediatrics. And there are specialists around doing practicing in the field, but they don't have fellowships necessarily where you can go and have in-person training.
So, as a mother who has teenagers in the house, and the difficulty of making my own teens listen to me, what are the unique challenges do you face when treating children and adolescents with obesity compared to treating adults with similar conditions?
Right. I do find that, well, even my own children don't listen to me, right? What do I know? I'm just but I do find that when kids come to me, they do seem more ready to listen. I think when you hear the same message over and over again from your parents, you tend to tune it out after a while. And I've even had patients tell me that the more their mother asks them to get up and exercise, the less they want to do it. So incorporating them into decision making can be really, powerful for changing. Yeah.
Let the decision come from them, or make them believe
Exactly.
it's coming from them. Okay.
Right.
That can be a very good
Right.
parenting tip, more than
It works most of the time.
let's go back to your clinic. So at Evora for Kids, what does the typical appointment look like? How do you begin working with a kid and their family?
Yeah. So I usually will have like a 15-minute phone call with the parent in advance, so they kind of learn about me and the practice and make sure we're a good fit for one another. And then I get all of their medical records from their pediatrician, their growth charts. I have the parent fill out a very extensive questionnaire before their first visit even. So by the time I see them, I feel like I already know them. If it's an older adolescent, like 12 and older, I have the child also fill out a really extensive questionnaire talking about appetite and eating habits and activity level and sleep and depression, anxiety, medical history, medications, all the things. So that's sort of, so before I've even, met them, I feel like I said, I already know them. So then it's a discussion, just looking at all the factors that could be going into what's creating this child's weight issue. And all in the context to, all conversations, we're not talking about obesity or you need to lose, X number of pounds. It's all like in context of health. So I go through, the whole history and do a physical exam. And then we just talk about, like, what do I see as the contributors to weight? So maybe this child has, a really strong appetite and just never seems satisfied. Or maybe this child has depression and is eating to cope with emotions, and kind of identify all the little things that could be contributing, family history, genetics, that sort of thing. So that sort of takes away the shame that people often feel and the blame, like parents blame themselves and kids think there's something wrong with them. And so that kind of neutralizes the conversation. And then from there we go on what can we do and what steps can we take.
So, childhood obesity itself is a complex disease. There's not one, it's not 1+1=2, but it's 1+1+5+8. There's so many factors. Yes, and it all comes together and creates this massive issue. It's a sensitive topic, even with adults, right? Even when adults come to you and ask you for help, it's a very sensitive topic. I mean, I have patients who've had heart attacks, and I tell them you need to eat differently and exercise more. They get so angry with me, and they kind of get annoyed with me, and I almost see like a fight or flight reaction in the clinic itself. How do you approach it with children?
I really kind of pose it as we need to make some changes. And these are the things that I see about your life, like where we could use to improve. And I tell them every time we come in, we're going to make a few choices together of what we're going to do. So I just kind of laid out there, like, that's the fact. It's making whatever changes are they motivated to make. So for example, I had a teenage boy the other day, and every time he eats or snacks, he's watching, his videos, his YouTube videos. And we talk about why that's not a good idea, how it doesn't let him hear when he's hungry or when he's full, this sort of thing. And he, nods along and says, okay. And then at the end of the visit, I say, like, what about the watching videos while you're eating? Like, what do you think about that? Do you think that's something we could cut back on? And he says, yeah, I could do that. Okay. I said, okay. And then I say, well, how many days a week do you think you could do that for? Because we want to be, really specific, setting smart goals. And he says, every day. And I thought, oh, wow, I wasn't really expecting it. Every day. Are you sure? Yes, every day. So now he's made that, like, it was his declaration of how he's going to do it. Yeah. I feel like most kids, I mean, especially when they're coming to me, it's a mutual decision. It's not just the parent dragging them in. Most kids do want to feel better. They want to feel better in their bodies, and like why it's so important for their overall long-term health. They know that in this moment they want to have more energy. They want to whatever. Yeah.
So, what is the youngest age of a patient you have treated with obesity?
In fellowship, we had kids as young as 3 years old. Yeah, and a lot of that is just more education for the parent. But if if their obesity is severe, then we're also looking for other, we're looking for causes, we're looking for genetic conditions and so on.
That kind of segues into the next question, because obesity in a child is sometimes, the biggest contributor could be the parents, whereas the older child could have exposure in school, etc. The younger child is mostly getting it from the family. And sometimes the child is not obese, the parents are also, carrying a lot of weight. So what are your philosophies to incorporate the family into the treatment plan?
Um, Definitely any changes have to be done as a family. We can't single out the child or even children. So, it's tough when there's one child who struggles with gaining enough weight and then the other child has too much weight, and we don't want to have different food rules and that sort of thing. Well, we don't want to have food rules in general, but we don't want to treat anybody differently. So we do just talk about how everything needs to be done as a family. And if there are things that need to change at home, like certain foods that are being kept at home, we have to, gradually start getting rid of those things.
So it is, this is such a tricky topic, right? Because these children, we are talking to them about calories, movement, etc., very young. So there is a possibility I hope, they get the message and they are able to stick to it. Have you seen patients cross over and get into eating disorders, and, taking this too far
Yeah,
and becoming anorexic and bulimic, etc.?
it's pretty uncommon when they're coming for medically guided weight management. I would say it's less common. If you think about what kids will do on their own without guidance, they tend to do more extreme things. And I think really the how we approach it is, like I said, always about health and never setting like a weight goal and setting just reasonable expectations too. So, for example, I don't necessarily try to get somebody into a perfect middle BMI range. We just want to get them to where they feel good and they're not having health problems. Um, and close monitoring too. So, I'm screening for eating disorders before I even see them. And we're talking about sort of unhealthy kind of eating behaviors or restriction, and then continuing to monitor that at every visit. And I see them once a month. Um, so that I'm also watching to make sure they're not losing weight too quickly. There's something about, some kids, they are genetically susceptible to eating disorders. And if they are severely restricting they're more likely to really develop those, disorders. So I do try to make sure that we're not losing too quickly.
Yeah. So now, obviously, this whole obesity medicine practice has evolved a lot in the past couple of years. Even though we had metformin and Crismia and other appetite suppressant drugs, the GLP-1s have, like, kind of, at least in the adult world, has overtaken the practice of managing obesity. How much of it has impacted the growing children?
American Academy of Pediatrics, Obesity Medicine Association do say we should offer medications to those with obesity. Um, don't use it for everybody, but yeah, we do use it a fair amount. We've had a lot of success with it. Children tend to have fewer side effects, and maybe it's because we're holding their hand the whole way about how to eat on the medication and what to expect. And again, following them really closely. So yeah, it's life-changing for some of these kids. I just happened to, I was already choosing to go into this field. It just happened at the same time of this explosion of GLP. So it was good timing, I guess. Because now I have more tools in my toolbox than I would have a few years ago.
Now let's kind of discuss a little bit of why is there this rapid increase in obesity? I mean, for adults, we know the processed food industry, etc. But for you, in your practice, what do you think has been the biggest contributor for the rise in obesity in children?
Well, of course, many of these kids have just sort of a genetic predisposition. It's thought that, I don't know, statistics are anywhere 40 to 70% of your weight is determined by what you've inherited from your parents and what your individual biology is. I think we are now putting people that are so genetically predisposed into this world of highly processed foods, of high stress, of sedentary, lifestyles. We're on the computer all the time. Um, I tell kids, I said, it's not your fault. You were born into a world where food is delicious and food is everywhere. And you and your friend may be doing exactly the same thing, and your friend looks completely different than you. Like, how is that? How is that fair? It's your genetics, it's your biology, that kind of thing. So I do think that the food environment and just lifestyle of just being less active is a huge contributor.
Sometimes obesity, when in adults, it's usually there's a big stigma. I mean, obese individuals don't get promoted frequently. Their pay is less for the same amount of work, etc. And adults themselves struggle with coping mechanisms. And I'm sure the similar stigma is there for children, and schools and middle school and high school. They're not friendly places. The children can be pretty rude to one another. So do you partner with psychologists? I mean, what are the other disciplines that you bring into to help you with these patients?
So many of my patients have been bullied. Like, that's one of the questions that I ask both parents and the child, and many of them will say they've been bullied, or sometimes even within their own family, comments from grandma, or they're often a sibling, really sort of make that worse. And we know that sort of bullying, the shame, stigma, whatever, actually kind of makes their weight even worse. Like, maybe they start coping with more food, or they start coping by avoiding activities because they're afraid of what people think. So I see that an awful lot. And we do, at my practice here, we do have a therapist who works with kids. And so, yes, therapy can be quite helpful. So some sort of a therapist is usually what we would suggest if needed. We don't always need that, but sometimes just validating them that feels really bad, and that it just kind of depends on where they're at, their mental health.
Do you give them a nutrition plan, an exercise plan, and how do you know they stick to it? What is the protocol?
I don't do anything that's really prescriptive, as in, go home and follow this plan. We kind of look at where they are, and we set those little goals together, like I was saying. So, we shouldn't assume that all kids are eating fast food and not moving their body. Some kids are doing sort of, quote, all the right things. They're eating their fruits and vegetables, and they're playing 3 sports, and they still struggle with weight. So I don't want to say that everybody needs changes, but we can all make changes, right? So it is more, where are they now? Where can we get to? So if it's a kid for example, some kids might be really picky eaters, and they won't touch a vegetable, to save their life. Sometimes we refer them to actual feeding therapy, like with occupational therapists who help introduce new foods. We see that a lot in kids with autism, and there's an overlap, autism as a risk factor for obesity. So I see that quite frequently, but we will just decide where they are and see where we can make improvements. So it's more almost like we're adding things instead of trying to subtract. So, can we add a fruit to your snack, or can we make your snacks look like this? And then we create some ideas, and we do that. So we don't try to do it all at once. I think it's too much to do all at once. It's hard to overhaul your life. For activity, many kids have smartwatches or smartphones. So we'll take a look at, if it's a kid that's not particularly active, we'll look at, let's see what your steps have been. How many steps have you had in a day? And they know exactly where to look. And I've had kids who are getting like 2,000 steps a day. And like, so we set a goal for, can we try 3,000 steps a day? And then they come back and we just keep chiseling away just little bits at a time. Yeah.
I'm sure each patient is different. How long do you work with them?
I mean, like over time.
Because I'm sure parents are like, I want my kid to lose 10 pounds in 20 days or 30 days or something like that.
No, I guess I haven't been doing it long enough that I've ever had anybody sort of just graduate and be done. Well, no, that's not true. I did have one patient in fellowship, but even still, we would have them come back, check in at least every 3 months till we see how they're going. But um, in general, it's obesity is a chronic condition, yeah, and we do warn them of that this is maybe something that you're going to have to deal with, for the rest of your life, and maybe not.
So, I'm sure there are no teenagers or adolescent children listening to my podcast. The audience is going to be parents who are listening to it. So, what would you advise the parent, who is maybe noticing harm? Because little chubby kids are so cute and so cuddly and so adorable, and how do they draw the line between this is cute versus, oh, my child is moving in a different trajectory? What would be the warning signs for a parent?
Warning signs would be things like if they're frequently like sneaking food, you're finding, lots of wrappers in their bedrooms, like the sort of secretive eating. If they are kids that seem to be just eating all the time, always asking and seeking for food. If their mental health is seeming to be affected, like depression, anxiety, withdrawal, that type of thing. If the child themselves is starting to express like unhappiness with their body, calling themselves fat, that kind of thing, those are all kind of signs. And then sort of, asking your pediatrician as you go, but you have to be careful with that too. If you are concerned about your child's weight and you don't really, because sometimes a pediatrician they might just not know how to discuss it just right. So it would be better to try to talk with them sort of, offline without your kid around, and see what they think. Where are they falling on their growth curve? Things that I would look for, like when I was in general pediatrics, is there a change? Is there a change in how they're growing? Because we're watching that growth curve over time, and like instead of doing this, if it's starting to get pretty vertical, then something is going on.
So when you all these changes make changing your snack, etc., but what if the child is still hungry? How is a parent able to navigate that challenge? Yes, mom, you've given me this plate, but I'm still hungry and it's irritable. How would you will probably have to, how does the parent deal with a hungry child?
One, eventually getting to a plate. We use the plate method for what we're feeding, and half of it is fruits and vegetables, a quarter is protein, quarters or carbohydrate. Offering fruits and vegetables as second servings instead of carbohydrates, or particularly carbohydrates. But if they're really, if I feel like they're just really truly hungry and we're doing all those things, then that's when medications like come in, and they can be very helpful. Even at younger kids, there are things we use off label to help with appetite, because it's just probably beyond the parents' control.
So now I'm going to flip to a different side. Do you have parents bringing in their teenagers who don't are not clinically obese, but they just want to make sure they fit in a particular size and come to you for medication?
Yeah, that's tricky. That is tricky. We do have to. I mean, we won't use. I wouldn't use medication for somebody who's not sort of fitting the definition of obesity, and not having any health problems either. Sometimes there might be somebody. It's a little. I mean, it's nuanced, because there might be certain sort of ethnic populations where like a lower BMI is still unhealthy for them, or if somebody who has a really high percentage of body fat, but they're still in a normal weight range, like there's some nuance there. But yeah, so when they're coming in, we just reassure them that they're normal, they don't qualify for medication. If we can talk about some healthy changes to make in general, but we're not going to like advise them on losing weight specifically. And we talk about how, again, like genetics, how not everybody can look the same or reach a certain size.
But unfortunately, that's what social media and the society is reiterating, that we all need to look at a particular way and a particular size, and it's the abuse of these medications to be now, super ultra thin kind of, it's becoming the mode. And I see a lot of girls struggling with it. That honestly, are your patients mostly female gender, or do you even get male gender patients?
I don't know what the ratio is. Maybe a little bit more girls than boys, but maybe 2 to 1, maybe 2 to 1 girls to boys. Yeah, those parents that come in where their child is maybe just right on the line and they're worried. It's often like as the girls are getting ready to go to college, the parents are worried that they're going to go off and like gain.
No, for parents who are listening and who are concerned about their child's weight and their health, what advice would you give them? What could be the first steps they could take by themselves at home?
As far as determining whether it's a problem or just how to make changes.
The child is getting definitely beyond the cuteness phase and into, okay, this is a problem. So how can they, what would be the few things they can say to the child, gentle fashion, and redirect the child's behavior?
It's going to be it's tricky, more like sort of open-ended questions with the child, asking them, do they have concerns about their health or weight? Doing your very best not to make any conversations about size or weight, and also watching your own language about how you talk, not only about yourself or maybe a celebrity on TV, like trying to like really refrain from, boy, she's gotten skinny, she must be on, whatever. Just that watching that language in general. It does, especially as they're teenagers, it does need to be kind of a mutual decision if they want to like come and find further help. But making changes, and then making changes just as a family, like, hey, as a family, we're going to start doing this, and giving them some input too. Like, I don't know. For example, I have a family where they go to fast food like 5 days a week, and the parent is really unsure like how to handle that situation, and two of them are teenagers, and I say, okay, well, how about you start with, you're only going 3 days a week, and they can each pick what day they get to go is their day. I don't know, it's something, it gives them some ownership. So you're still the parent, you're still like setting some guidelines, but you're giving them some input.
Most of the time, one of the reason for obesity pandemic or epidemic is, mothers started working. So, and we went from a multicultural family to more nuclear family where both the parents are working, and sometimes they're working two jobs and there's no time to make good healthy meals, and that's why the fast food culture came in handy. At least you're providing them with some calories and some nutrition. So for a busy parent struggling, trying to make ends meet, and when there is cheaper fast food options, how do they navigate this space?
It's challenging. It's really challenging. We often will have them working with a dietitian to try to come up with some affordable, manageable, easy meals. And when the kids are old enough, teaching them too how to cook, and kind of trying to find foods that we can keep in the house that are like meeting with our health goals. But it's hard, and that's like one of those social determinants of health, that those that are really struggling to like make their dollars last through the month when there's a, $5 special at their local fast food restaurant. Like it's hard not to. Um, yeah, that's really challenging. So uh, I don't have, I'm not having that population in my practice here now, but in training we had resources, social work. We direct them to farmers markets and places where they can get some healthy foods. There's programs like voucher programs that can be helpful to kind of move in that direction.
So when these kids are growing and we're worried about their health, we want them to keep growing tall and keep going strong, etc. And now we're talking about, do you tell them calorie restriction, or do you tell them to just change what they are eating so that their growth curves are not disrupted by their changing in diets?
Yeah, I don't do any calorie counting typically unless we're really, really we're really struggling. So yeah, it's more like change what you're eating, adding, like I said, adding foods with fiber and as our fruits and vegetables or protein or whatever is missing, balancing out what they're eating is what we would do.
Are your patients compliant?
I think they are. I mean, they try. I mean, they come in and they're trying. Definitely, yeah.
I mean, obviously, compliance is the biggest issue. So I guess if they're coming back to your clinic, then they are definitely compliant with what the program is.
Right. And if they're on medication, that helps. That really it makes such a big difference. And they can make healthier choices, and they do. That's sort of the magic of some of the medications. I do tell them. I say, if we're putting them on a medication, I'll say, I'm not giving you this so you can skip more meals. I'm giving you this so that you can have more balanced meals, eating them more, regularly, that sort of thing. So, and that, and I kind of sell it in advance, like, this is going to change, like this probably will change, your tastes in food, and it's going to make it easier to make these other choices. And I do think, I mean, yeah, it would be really hard without the medication.
Could you share a story? I mean, obviously, without any identifying details, that illustrates the transformative impact of the approach you've taken.
Young woman in fellowship who was on not on a GLP-1. She was probably 15 years old and over, I don't know what the time period was, but she lost 100 pounds. She lost 100 pounds. Yeah, on not a GLP-1, on using some other medications off label like phentermine and topiramate. So, and I always told her, I go, you're going to be my example when people think I know this girl who took these two medicines.
And those are even cheaper alternatives to the
So
GLP-1.
cheap. Yeah, insurance companies don't even blink an eye at topiramate. It's not even worth their effort. It's expensive. And that's what these folks, that I trained with, that's what they were using until they had GLP-1s. They had, phentermine and topiramate and sometimes ADHD medications too.
I think you're absolutely right, because right now, we as physicians, like, oh, we tell the patients to eat right, etc., and they should follow that plan. And if they follow the plan, they should get there. But then you look at the socioeconomic factors, the emotional factors, the hormonal factors, and it just adds layer after a layer after a layer. And then sometimes people are very hesitant to seek medications. Like what you said, you don't need to get the most expensive kid on the block. You have this phentermine and the Kismia one, atopiramate at a much lower dose. And I'm in the presence of a doctor. You're checking them out. You're making sure all the side effects are all well controlled. And it could be life changing for a child and for an adult. But oh, I can use willpower and I can power through this, and you struggle so much with that. And I find it very, they rather struggle with where they are instead of taking that initiative to let me seek treatment for it. Like if I have an infection, I'm not going to I'm not going to say my immune system needs to fight it and not take an antibiotic. But when you're fighting with obesity, it's still a taboo, right? Still a taboo to.
It's a big mind shift. I definitely will talk about how I sort of blame it on the brain, right? Our brains are wired to not lose weight, and when you start losing weight, they say, "Oh no, I've got a better idea. Like I'm going to make you hungry. I'm going to make you tired, and you're going to gain your weight right back." So we get right where we were. And so, and if families are just not, they're not ready for medication, definitely don't force it. It's a mutual decision. So we just try to work on those changes, and then oftentimes after trying for a while, then they come around to it's too hard, like they're too hungry, they're whatever, and then they're willing to try. Or parents are. I'm seeing more and more who parents that are taking medications and seeing how much it's changed them, and they want the same thing for their child, and then they come. Yeah.
For adults, at least, we say BMI is a very poor scale of your obesity, because if you're big and muscular, the BMI could still be in the obesity range. So what do you use for children? I mean, the number on the scale may not be an accurate reflection of their health itself. So what do you use as a measure?
Right. I mean, BMI is still sort of the best, easiest accessible tool that we have. It's not perfect, but it does capture most children who do have true obesity. And yes, of course, there are some athletes or people at extremes, in which case, we're doing more and more body composition testing too, although there aren't a lot of great standards for kids because they're growing. So the BMI, the BMI is still sort of the best tool. What's nice about BMI in kids is that it's age and sex specific. So like what's normal for a 13-year-old girl is going to be different than what's normal for a 13-year-old. So in adults, I do still think that's kind of odd that we use the same sort of BMI range for men, and it doesn't make sense because we are definitely different. Um, uh, and so, yeah, so the BMI is still what we use. It's like acknowledging that it's not perfect. And then if we are sort of losing weight, or maybe we're just maintaining weight, we're just using the BMI on that own child to compare themselves as to, where they've been, where they're heading. Like we look for the BMI to kind of level off, like, so that, which meaning, weight gain has either stopped or slowed down and they're still growing. Because eventually, like, for example, some kids could be like an 8-year-old that weighs 150 pounds. If they didn't gain any weight till they became, 16, that's okay.
We are coming close to the end of our discussion here. If there's one message you want to give to a parent who is like, this could be my child, what would that be?
Yeah, maybe two messages. One is not your fault. Like, don't blame yourself. As mothers or fathers, we tend to blame ourselves first. And two, yeah, just start asking questions. Ask your pediatrician. My website has got a lot of good information on there, a lot of blogs about different things you can do and what goes into, causing a child's weight, looking at everything, like looking at their mental health. Is that under control? And then what are we doing as a family? So.
Yes. Well, Dr. Trito, thank you so much for sharing your expertise and insights and your experience today. I thank you. I think we got a lot of information. So if they want to learn about your work at Evora for Kids, where can they find you?
Yeah, our website is Evora for Kids, EVORA, forkids.com. We're also on Instagram and Facebook, same tag, Evora for Kids. And there's a few videos on YouTube as well from some community talks that I did, one with one of our dietitians and one with our therapist too. So
that concludes our episode with Dr. Lisa Trito. Thank you for listening to Reboot with Dr. Arasi Maran. If you have enjoyed this conversation, please subscribe to our podcast and also refer this to your friends and family who may benefit from this. And please do leave us a rating or a review, which helps other people find this podcast. With that, it's never too late to reboot your life and reboot your health. With that, I will say goodbye. Thank you so much for listening. If you found us valuable, you can subscribe to the show on Apple Podcasts, Spotify, or any of your favorite podcast app. And also, please consider leaving us a rating or a review, as that helps others find the podcast too. I hope you have a great week ahead.